Dr. Matthew, for your kind words. And I must congratulate Professor Usha. Despite she had recently some setback in health, she was so energetic to come back for this session. That shows his dedication in the academic program. And this is the combined efforts of the three premier institutes of India. I must congratulate the organizers, apart from Dr. Usha and the team, PGA, AIMS, and SGPGA program. And what she is concentrating to the postgraduate, it will go in the long way in the learning process. Last year I gave the same topic. She said I should give the same topic once more because it is so vital, and it is the not only bread and butter and jam of any endoscopist. And colonoscopy, as Matthew Phillips said, may be very simple, may appear, but if you get into one perforation or one bleeding, you know the technique. The most important thing in colonoscopy is it is not that you're reaching the cecum. If you don't reach the cecum, why you do not reach the cecum, you have to know, then only we can progress further. It is not shoving the endoscope and seeing the terminal ileum. In what are the ways you have gone through that? So, what are the difficulties you had there? This is an important thing. I bring warm greetings from Chennai to the dear postgraduates. Now, this is going to be a three-dimensional approach. First, I will give you some text material which will really highlight the importance of colonoscopy procedure. As Matthew Philip rightly said, it may be before starting the procedure in USA, anyone above 50 years of old, they should undergo colonoscopy because the cancer surveillance program. It will not be very far off in thinking about Indian scenario. In the last 2 years of COVID epidemic, we have seen people coming very late, and I was surprised to tell you that we had identified almost 10 cases of total colonic obstruction because of the colon growth. That means we need to really gear up with the colonoscopy technique and to go for the cancer service. Cancer surveillance. The clip art I'm going to show you some diagrammatic, the cartoon, how to explain the various tips and tricks, and certain videos which you have really taken during our workshop. I want to highlight with the three-dimensional approach. I think we'll be able to tell you the tips and tricks of the colonoscopy procedure. It is not a run-of-the-mill lecture, okay, routine lecture where I can just copy something and then. So what I have designed, what all I found it very important for the postgraduate, you may call it as a pearls of experience. Okay, first of all, you should know the anatomy, rectum, and rectosigmoid. There can be yet trouble in entering into the sigmoid. Sigmoid and descending colon, there can be a trouble. Splenic flexure into the transverse colon. From the mid-transverse colon going towards the proximal colon, and hepatoflexure, cecum, terminal ileum, ileocecal valve, everything colonoscopy essential. Even though the name sounds large intestine, please remember this is a thin-walled structure. Perforation can happen. The other thing we have to know is mesocolon of sigmoid and transverse colon is quite variable in length. That complicates the problem of various loops like the alpha loop and the gamma loop and other thing. And the persistence of mesocolon. Again, normally the descending colon and ascending colon is a retroperitoneal structure. But if congenitally they have mesocolon, then you can have a reverse alpha and other reverse splenic flexure and so many things like that. So you will be wondering why we should know about loops and areas, various bend and maneuvers. My aim is just to read the cecum. I am always done with the 80% of the cases. I am not bothered about 20%. No. Now it has made it very, very clear. American Society of GI Endoscopy and all over the world. Once you document the cecum, you have to cecal intubation picture has to be there, and terminal ileal picture has to be there, and ileocecal valve. The other important thing is withdrawal time. What is withdrawal time is from cecum to the rectum your withdrawal time should be calculated at least not less than 7 minutes so that you are not missing any polyp or any structure. Okay. Now there are do's and don'ts. I follow certain rules. Very, very stringent in inflating the colon with the air. The more you inflate, the sigmoid is so descended, you will be only in the sigmoid colon. And you'll be thinking that you are doing for the procedure for 30 minutes, but nothing happened, you are in the sigmoid colon. Suction is the key for success. Very important is the more you suck and collapse the colon, then you will be able to proceed further. Withdraw the scope when you cannot see the lumen. That is a very, very important thing. Many people think that if you withdraw that, you will fall down and you are losing the length. No, if you withdraw the scope, you cannot see the lumen. And another important thing is 1:1 push. Very important to know that here is, if you push 1 centimeter, you should progress 1 centimeter. That is called 1:push. Sometimes happen you keep on pushing and shoving the endoscope from the anal root, and you will be not be seeing the progress. You are not going ahead with the transverse colon or sigmoid colon or the. Then that means the mechanical transmission of scope is very important. Understand the formation of various loops. Sir, I'm very bothered about loops and maneuvers. I don't want to understand. But if you do not understand why you are failing in some cases, then you will not be able to proceed further. Moreover, understanding the loops and maneuvers will help you really to shorten the scope and reach the cecum and the shortest time possible. There is one technique I want to be very careful. You should not be very rude. The sliding technique, the scope slides along the wall. You are not seeing the lumen. The teaching is you see the lumen and proceed. Sometimes you're not able to do that. And along the wall without blanching the mucosal vasculature. And here the lumen is not seen. That is called a sliding technique. I would request that you should learn it when you get the expertise. Learn to shorten the scope. You are 1 meter and 40 centimeter in the cecum. You can bring it to 7 centimeter. That is the ideal length where you are able to see the cecum. Anal fissure, don't proceed. Painful. Actually, then you treat the anal fissure or lubricate nicely. And whoever the owner of the scope, please, or in the workshop also, don't unnecessarily twist the scope to the maximum so that you can break the thing. No, twisting the scope will not help you beyond certain level. And don't forget to do the J maneuver as you do it in GI, upper GI endoscopy in rectum to look for lower rectal lesions. Sometimes, many times you miss it. In fact, my surgeon insists, I also insist to my colleagues and postgraduate, after doing a nice proctoscopy also very important to pick up the lower rectal lesion. If you're not able to do the J maneuver, sometimes J maneuver may be difficult in a therapeutic colonoscopy, then you don't want to spoil that. So better do a proctoscopy. It's also part of the colonoscopic colon examination. And we try to identify through the transabdominal light transmission. That is wrong actually. The cecum should be identified the convergence of tinea coli and appendicular lumen and ileocecal valve. Once I remember that the patient, my colleague, the postgraduate had a distended sigmoid colon. So the light illumination was seen in the right iliac fossa. He was thinking that he had reached the cecum. That is not the day to know that. So you have to see the anatomical landmark and do that. And many people reported past of the 30 centimeter, 40 centimeter. That does not mean anything. 60 centimeter can be at cecum and 60 centimeter at sigmoid too. Once I introduced the withdrawal time in our unit, a junior most postgraduate said that, sir, he waited for 7 minutes at cecum, then quickly withdrew the scope. That is not the withdrawal time. You have to be centimeter. But I tell them one step ahead. You have to scan the colon millimeter by millimeter, not to miss the polyp. In case if you miss a polyp in the cecum and 2-3 years later you develop a colon cancer, you demonstrate, there can be a legal issue also. In obscure GA bleed and lower GA bleed, never ever forget to go into the terminal ileum. You can be a lesion there or maybe blood coming from there. The tight ileocecal valve, the blood may not be coming to the cecum, but it will be the terminal ileum. That will be a clue that where is the obscure GA bleeding source is. Push the scope very slowly and steadily and pull it watchfully and carefully. That is again very important about this. Okay, now coming to the alpha loop, it is due to the lengthy sigmoid mesocolon. You try to understand why some people develop alpha loop, some may not do that. And reverse alpha loop and the reverse splenic flexure is due to the persistence of descending mesocolon. And I've seen cases, rarely, not very frequently, gamma loop due to lengthy transverse mesocolon. To understand that, I really had to take a lot of efforts to read it. And now I can make out why. I can even undo the gamma loop also very clearly, and alpha loop, reverse alpha loop. Beware of the lengthy colons and complicated. And Indian women particularly, I don't know why the reason they have a long colon, sometimes because maybe pure vegetarian and maybe long colon, so you'll be taking more time. And beware of lower abdominal surgery, cesarean, hysterectomy, etc. Pose challenge to perform colonoscopy. Having said about that, never compromise on adequate preparation. I am not going to the details of the preparation, and make sure that cardiac state is all right. The reason is you are dilating the colon, vagus stimulation, bradycardia may be there. You will be very enthusiastically doing colonoscopy to read the cecum, and patient may be perspiring, sweating, and falling so saturation, and they develop infarction also. In fact, the beginning of my career, I don't know whether Matthew, I've told you, I used to keep a mirror because you are the back. You are not seeing the face of the patient. So you are doing more concentrating in the bottom and pushing the endoscope. So I used to keep a mirror to see the face of the patient so that he is sweating or not, how is he reacting to the pain, another thing, very important. And don't over sedate it. The patient may not be able to appreciate the over distended colon. These are the very important thing. Inadequate preparation, more air insufflation, and more difficult procedure. The work rule is simple push. If you're not able to proceed, withdraw and push. And you can try sliding technique, call it a hard push. Undo the loops, abdominal pressure, change of axis of the endoscopy shaft, or change of patient position. All these things work over, and over a period of years of doing it, several, at least minimum 250 colonoscopy must do that, and make sure that you don't complicate the bleeding, perforation. Perforation can be a small hematoma in the antimesenteric border or mesenteric border, antimesenteric perforation. And if you see very unusual structure, then you are perforated. You have to be very careful. Sudden saturation, other thing. What is the clip art? The right hand controls the shaft now very clearly, and the left hand controls the wheels. This is what the right hand, I think most of them are right-handed, and a scope is in a straight standing position. You don't go on towards the anus and start looking at it, then you will be infected. And yourself is very important. There is a slight incidence of tuberculosis among the colonoscopies. I found it in local area of Chennai. So I don't know the reason, but make sure that you are little away from the anus and be straight. The first sigmoid bend is around 15 centimeters from the anal verge. As much as possible, as quickly as possible. You cross the 15 centimeter, the well begun, the well done. If you start the procedure first like that without getting into the loop, then you are very successful. The scope passes anteriorly into the sigmoid colon. Just visualize like that. And the sigmoid loop is restricted by the hand pressure if you want that. I rarely use it because I don't inflate it colon so much. Till I reach sigmoid colon and descending colon, I'll be very, very careful in inflating the air. And fixed acute angle at sigmoid and descending colon. These are very, very important. This is the area, major area of perforation. You know why? Sigmoid is a moving organ, like a mesocolon, we have that. And descending colon is a fixed one, retroperitoneal. When you are moving from the fixed one you are going, there bound to be something. So how to overcome this? Mostly this is the very important area of negotiation. The acute angle at the level of sigmoid and descending colon junction is decided by the, I am not going to go into the why it is like that, mesentery and extent of retroperitoneal fixation. I have analyzed it, it's written in the book. The tip of the scope passed into the entry of the descending colon, pull back. This is the way you pull back, you come out, then you will try to enter it. Very simple because you are sorted. Sometimes you can take the advantage of the alpha loop, you keep pushing it, and then the acute angle between from the sigmoid and descending colon disappears, and this one. And counterclockwise rotation of the shaft of the scope, alpha loop is formed. This is a very important thing. Rotation of the shaft of the scope, alpha loop is formed. So what you do is you have to move the clockwise and anti-clockwise rotation, and accordingly you do that, and you form the this one. Alpha loop, a beneficial iatrogenic valve in case of acute sigmoid and descending colon junction. You for that you want to understand. For a beginner, you have to read thoroughly, internalize, understand. For any endoscopy procedure, you have to internalize. After that, conscious learning, it becomes an unconscious learning. Alpha loop is straightened by clockwise rotation and worsened by anti-clockwise. How do you know that? This is what you have to know, that the sigmoid mesocolon coming anteriorly, sigmoid, then going posteriorly. All these things you have to know that. And view of the alpha loop from front, view of the retina shaft will advance in the scope, give sigmoid colon straight and deeper insertion into the descending colon. This is a fantastic way to enter into the descending colon. And then you get impacted at the level of splenic flexure. So what you have to do that, and whatever bending the scope, you have to straighten it. The impaction will disappear. Then enter into the transverse colon. Suction followed by pulling back the scope improves the view at the acute bend. This is a very important step. Suction is the key. You have to know that. Compression by hand or sandbag. I never tried in my 35 years of practice sandbag, because I am very, very careful about the inflating the colon. Maximum we have done with the hand, but sandbag is not a bad idea if you don't have someone to help you with the compressing the hand compression. Tunnel view of the ascending colon at hepatic flexure, and straightening the colon possibly by pulling back. Pull back, you will succeed. You always be humble, you will succeed. Your withdrawal will also help you to succeed. And after that aspiration, the hepatic flexure towards that, again, you are sucking the air. Your aspiration of air and fluid at the ascending colon helps you to reach the cecum. And measurement at various anatomical landmarks, if the scope is in the cecum, this is what the measurement, if you see that very clearly, 50 centimeter, 80 centimeter, 70, and 20 centimeter. And within 4 to 5 centimeters from the cecum, blind end, you have the terminal ileum. And ileocecal valve is approximately, you have to know that, go past the ileocecal valve. And what you have to do it, you can do it in the left lateral position or supine position. I'll teach you in a supine position, very easy. And how will you turn it? And this is what the videos I'm going to show you that. This is showing the rectal valve. You have to know count 3 valves. If you cross the rectal valve, you are entering into the sigmoid colon. So try to enter into the sigmoid without inflating the air. This is the very important. I'm using fluoroscopy as a teaching CD. We have created 14 teaching CD-ROMs in various endoscopy technique. Those postgraduate who want the colonoscopy teaching CD, we have one basic and advanced. They can write to me, I can send it to them, or I can send it to Professor Usha. She can distribute it to all the postgraduate. I'll be very delighted to do so. So this is what I want to tell you about rectal valve. And the final rectal valve, now you are entering to the sigmoid colon. Okay. And this is again to show you that the moment you reach the sigmoid colon, don't inflate air. I'm going to show you the finger pointing sign. What do you mean finger point? I do not put my finger into the suction at all. I mean the air water. So if you inflate air, what happens? Again, you get bloated and get lost. You get whole scope get finished within that sigmoid and descending colon itself. So this is a very important pointing finger sign. This is what I always tell my postgraduate. Like that, I want to tell you that various steps we have discussed in our teaching CD, and this is just to show you how the endoscopy procedure. And you don't need to do fluoroscopy routinely. I have done it for the sake of teaching. Otherwise, you don't need it. Nowadays, teaching aid is also available. This is just to show how the alpha loop. Either you can exaggerate the alpha loop, enter into the descending colon. This is the retroperitoneum, close the spine descending. Or you can undo the alpha loop and you can enter into that. So you do the clockwise rotation, you can undo. There are 2 ways of doing the colon alpha loop reduction and entry into this. Again, this is just to show that how we are teaching CD where we have that the scope, external movement, and the fluoroscopy, and we are trying to enter from sigmoid to the uh, transverse colon. I want to show you the bluish discoloration, which is very typical of splenic this is the bluish discoloration of the venous plexus uh, overlying the colon mucosa, and this is what it is. Now, okay. Now, various colonoscopy videos we have taken in, it just shows how to identify the cecum. Now, I'll tell you the ways to enter into the terminal ileum, and you go past the ileocecal valve and withdraw it and turn to the left towards the 5 o'clock or 7 o'clock position, the terminal ileum, you have to know that you can enter into that. I'll show you one more video how you can enter into the terminal ileum. So there is endless way of teaching aids are available. Only thing you have to master it. So this is the ileocecal valve to show that upper two lips of the ileocecal valve. This is to demonstrate the J maneuver in the rectum and how we do this J maneuver. But very careful, you have to inflate the rectum nicely. If the rectum is not inflated, you may damage the endoscope. This is what again. Now, finally, there are several advances happen: endocuff vision, water filling colonoscopy, third eye colonoscopy, where when you want to see in advance, when you are withdrawing the scope, you'll have a third eye, and artificial intelligence. I will not go into the detail because the scope of my talk is only tips and tricks in colonoscopy procedure. The water filling, if you have a spasm or you are not able to see that, some mild narrowing there because spasm, you can fill up the water. This is the water for prevention of barotrauma. And I have taken this courtesy from Dr. Douglas Rest, president of American Society of GA Endoscopy. And I've taken the video from him also with his permission. And this is the endocuff vision. Because the polyp is a major problem in USA, colon cancer. It is not a major issue, but slowly we are also seeing. Now we started using this kind of technique to identify, not even miss one polyp. Again, you have to be excellent. When you have to be excellent in your technology, for that you need to have a very good preparation, and you have a satisfactory examination of the colon from terminal ileum to the rectum. Very important to do that. And don't forget to see the lower rectum with the proctoscopy also. And in conclusion, the stages of competence. I always tell this, whether you're going to learn upper GA or you're going to learn the colonoscopy, unconscious incompetence first. You will be wondering, will be worried about whether you'll be able to reach the cecum or terminal ileum, and you don't know that you don't know. Conscious competence, incompetence will come now. You know what you don't know. Then conscious competence. It may appear more difficult than colonoscopy, but this is what everyone will go that you know what you know consciously. Very important this is. And unconscious competence. You know what you know subconsciously. So like driving a car, you will never know that when did you apply brake, when did you use the accelerator, when did you turn left to right or everything. That becomes so subconsciously. You will be called as a master. Two things: start doing it subconsciously without any complication or complication acceptable range of international standard and beneficial to the patient. And I used to wonder, the doctors keep on, my colleagues in Rotary Club, they ask me, why you doctor keep on learning and all. Today's trainee is tomorrow's trainer, and today's trainer may be tomorrow's patient. So teach everyone for the benefit of everybody. This is what I used to tell them. So because life is very precious, we need to have the most technically sound person who can do a very ethical job. This is what I think. Just 30 minutes now, I made it the tips and tricks of colonoscopy, three-dimensional approach. With the what I have done is, how will you do the clip art and videos and the text. And colonoscopy, don't take it very lightly. The reason why we should not take it, you don't know what is ahead of the tip of the endoscope, whether it's going to be a bend or the loop or a stricture or a lesion or a normal colon. So you have to blindly proceed, but you have to proceed intelligently. And where you are at the level of the colon, you have to know very clearly and without inflating, looking at the face of the patient that is not sweating, not abdominal distension is not there, and there is no hemodynamic compromisation. At the same time, I will never agree to do a colonoscopy without sedation, however patient is willing or however patient is denying. I will explain to them. The reason is some people tolerate very well, but mostly they do not tolerate the colon, the intolerance, the colon distension. Nowadays, in our unit, we start using carbon dioxide in case, because ours the training center mishap happens, and we know that carbon dioxide is absorbed better than, particularly if there is a therapeutic procedure. Particularly, we know that colonoscopy done elsewhere, and they come for second opinion to do the procedure, to complete the procedure, other important. And if you, despite all the thing, you call your senior if you are not able to proceed further. And very important, when you have a very severe colitis or when there's a diverticulosis, where you are not able to negotiate, please call the senior whether worth the proceeding or not. And you have a friable growth, and be very careful in keeping the, your scope progressing with the, across the friable growth. Suddenly you will see the lumen of the, you will enter into the peritoneum. So you have to be very, very careful. Despite all these measures, you are not able to complete the colonoscopy, you are not able to enter the terminal ileum, you please make a point. I'm not able to go beyond this because of this reason, and I'm not able to see this, get into the terminal ileum because of this reason. If you make it, then the report will have value. And you have to write a very nice, detailed report. It's not like past of this secum, everything normal, I am normal, he's normal. That should not be the report also, and should be returned in a very proper format. What all you looked into that, you should make a mention how the mucosa, vasculature, any granularity, even negative points also you have to write. No granularity, no stricture, no pseudo. All these things should be, instead of writing normal colonoscopy does not convey any meaning at all. So with this, I just, I'll be happy to take up some questions at the end of the session. And this is what the my talk about colonoscopy tips and tricks. And please read the Peter Cotton book at least 10 times the beginner when you join the DM postgraduate or dependent post-graduation. Read thoroughly. Try to internalize what is alpha loop, what is reverse alpha, what is reverse sigmoid, what is gamma, and what are the things. Many people will discourage you, don't have to know anything. Just keep pushing the scope, you will read that. That concept, I will not like it. I will not approve it. I will not advocate it. The reason is, how do you learn swimming? No, you get into the swimming pool, you will learn sometime, you will do it very well. No, you have a proper mentor and guru, you will be very successful. Most important, if you are not successful, you should know why you could not complete the colonoscopy. Thank you very much for this wonderful opportunity.
Thank you, TSC, for this wonderful masterly talk. And you have shown us that the combination in teaching, combination of diagrams and videos and legends and all these things are quite important. And you have utilized all the three different 3D. What you told is 3D. I think the three dimensional type of teaching. It was excellent. We all liked it so well, and I also learned a lot. And your concept of just pushing the scope, it will go into a cecum. It may be true for TSE, not for all. In TSE, just push, it will go to a cecum, not for everyone. I agree with that. And there is a question that regarding that you have told us that you sedate all your patients. So one question is that will you select your patients for sedation? Not in your case. Another is, is there really any difference between sedated and non-sedated, which is better? And what is the ideal drug for sedation? This question is by Dr. Pradeep Nigam.
Okay. The sedation, why I choose this, if you need to have a cancer surveillance, you need to do repeated colonoscopy for a procedure. That's an indication he should come back to you. So suppose you are doing the APC for the proctitis and other thing, you should not feel that you are, and first colonoscopy should not be very painful. Number one, you are planning for a therapeutic procedure, you should do that. And if you have a cardiac issues there, You have a proper anesthetist with you and sedated. And young patient, otherwise you are expecting a normal colonoscopy. He is brave enough to agree for that. Then actually there is no criteria where whom to be sedated, but most of the center they sedate the colonoscope. And the first 100 cases by a beginner, the patient should be sedated because he can do a proper exam. Otherwise, the patient shouting, he's shouting, the nurse is shouting, and he's jumping, and that should the scenario should not be there. And the next room doctor will be asking what is happening and all. Are you doing colonoscopy? That kind of thing should not happen. And people earn a bad name for the procedure also. And doctor, you do anything but for that colonoscopy. The doctor really did the bad thing. I think that kind of fear among the public also can be avoided.
Agreed. TSC agreed. I think the most important thing is the patient. Uh, the patient should be comfortable. If you want to do a proper colonoscopy, the patient should be quiet and patient is comfortable and patient is looked after. So, in the same context, can we ask a question? In which patients will you do an IV anesthesia or a anesthesia procedure instead of sedation? Whom will you use anesthesia?
Okay, that's a very good question. Actually, what we do is uh, there are sedation without anesthetist, sedation. Our we can do it ourselves with our nurses, trained nurses and doctors. So these are the people, young people who will tolerate no comorbid disease, and we want to do a diagnostic colonoscopy. Only we do that, and we use the pentazocine and the other medicine meperidine we use this. But those who need to undergo a major procedure or comorbid disease, we'll have the anesthetist where we'll have the propofol, this one. And you don't need a general anesthesia naturally. So this is how we do it. Not all patients you need an anesthetic. The reason is anesthetic may not be available sometime. Then you have to wait for them. It prolong the procedure. So I will not advocate that. And you have to select it according to the age, comorbid disease, and the past experience of not cooperative. Today, all these things can come into the propofol. Do other things you can do it. Your own safe sedation is possible, but only thing I advise them to have the good monitoring with the saturation and the pulse oximetry, and I would love to have the ECG monitor also. This is easily possible that. And I will not agree with that. Those who are sedated will consume more time shifting the patient, other time and all. I think you need to have 1 or 2 tables extra and you have to do that. Then only that will be very useful. Just because lack of time, lack of manpower, lack of your space to shift and all, that will not be a criteria not to select a sedation.
Thank you, TSC. In other words, you want to say that anesthesia is given to those patients who are uncooperative, patient who has got significant comorbidities where the anesthetist is necessary and rather you have no time to look at that, or when you do a major therapeutic procedure which take time or the procedure is painful. Agreed. And another question is, it is that how well you assess a patient for his patient is prepared or not.
Okay, that's a very good question. Actually, yeah. Once what happened, we called the anesthetist, everything done. And he was also busy anesthetist. He came and everything. We just entered the thing full of, the colon was totally unprepared in the sense. So we are already given sedation. So one thing is one rectal examination will help you. Double dose preparation. The previous night, we found it very useful. Previous night preparation of and next day morning preparation around 11 o'clock, 12 o'clock, they are very fine to undergo the procedure. One is the concept of preparation. Number two is you have to questionnaire, you have to ask that. Everyone will say that they want haste, they will say, oh, everything done, it's coming and all. So we ask clearly what is the liquid or semi-solid, number one. Number two, what was the color of that. So the questionnaire will help you. This has been reported in various journals also. The questionnaire will, the color of the effluent and the what is the state. Is if it is a liquid and a colorless, then we agree with that. So that is the one. Number two. Number three, I do a rectal examination before sedation. If the finger stall is very clear, then these are the three ways. And you have your own way, Matthew?
Yes. No. I think the most important thing is that when you give an anesthesia to a patient and you find that the colon is unprepared, it makes a problem. So you should have.
And another small advice, I mean, the suggestion is that before giving anesthesia, I'll ask my colleague to just do a sigmoid, just enter into the rectum and see. If that rectum itself very bad, then I will tell my anesthetist, I think we'll prepare it a little better and we can postpone the procedure.
I think the most important thing is looking at the stool sample, and that is the most important thing. Now, if they can show that is what we follow. And one more thing that at the same context, I know TSC, you had to be very brief in your answers because there are so many questions and we have no time now left. And another is a patient with CKD, or when there is a patient who is taken up for an emergency colonoscopy, what will be your advice on preparation?
Emergency colonoscopy, we do it in GI bleed only. You have to learn to do it. I just do the only the enema and I proceed to do that. And my aim is just to look at the bleeding lesion, number one. Number two, then we don't use the phosphate containing all this thing for the CKD. We get the approval from the nephrologist and go ahead accordingly. And all preparation should not be used indiscriminately for all patients. And we select a patient and be careful of the monitor. I mean, nowadays no one is using monitors. That is out of question now. When we were students, I just want to tell you in the lighter sense, how did we prepare in 1980? We used to put the riles tube and hang it 5 liters of water, total gas, total colon, total intestinal lavage. And we are the resident, we have to look at the bottom of the thing, what is the container. And the water here and the water there is equal, mean Dr. JBD will agree for colonoscopy. It was the time, now it is totally changed. Now you can guess my age also now, because telling this incident in 1980 happened.
Okay. Yes, no, there is no change in your personality. No, we have seen the video of 20 years old. You are looking same handsome as the same one now. There is no change. But anyway, we have another question is that how do you change is there a need of changing the position of the patient while you negotiate bends?
Okay, and that is a very good question.
Very
I'm done with all these slide push technique, that's the final one, and I'm not able to proceed. I try to shorten if not possible, then I'll change the position. Not routinely, I don't change the position. And for terminal ileum, sometimes I change the position of the patient from left lateral to supine. So change of position is only you are done with the other techniques and then only. It is very difficult to change the position when the patient is sedated, particularly obese patient. You need to have someone to help you. So change of position is advised when you are done with the other techniques and not possible, then only I change the position.
In other words, supine is better for ileoscopy, no? That's what
I can understand the anatomy better.
And on my last thing, because we have no time, you have told us how to do colonoscopy. You have told us many things on colonoscopy. You have shown us different techniques. But for a postgraduate student, what do you think the learning curve for colonoscopy and how you should learn? Is it on models or watching and or starting under supervision?
Okay, this is combination of all three. First, reading. Read the book, read. Watch the video. Then if you have a module available, teaching module available, you go into that and see the color atlas to know what is the thing. So books, video, module, and the atlas, then observe the mentor, how is he doing it. Most important is selection of patient and all these things you have to be very good. After that, he knows the indication and contraindication and watching the procedure. Then in our unit, what do is, for the beginner, we don't give the colonoscopy straight away, we give them in the cecum. Let him learn to withdraw the scope so that you will see the lumen, and I'll tell them keep the lumen in the center and withdraw the scope. I hope Usha also must be doing the same thing, or everyone should do. And cecum, you give that, and they will withdraw the scope nicely. They get a hand-eye coordination. Then I give from rectum to sigmoid. And sigmoid, I'll be very careful supervising whether he's not able to, I will help him. Then I will hand over the scope again to him, descending colon. So this kind of mentorship, if you have that, you have a fantastic way of preparing himself for the colonoscopy.
Thank you, TSC. It was a masterly talk, and I think what you told in the last is very, very important for postgraduate students to start with, who are starting with colonoscopy. What I do is I give them at the cecum, ask them to withdraw. and see. But you have to watch there because polyps should not be missed. So the mentor should stand there and see that how he's withdrawing, and that he will get a hand-eye coordination really well. So I agree with that, and it was a wonderful talk. We all learned a lot, and even I'm an old man, I learned a lot from your talk. And
you're not an old man, you are very young in heart, learning, number one. Number two, one final statement I want to make here is, please do not underestimate colonoscopy procedure. Yes. Number one, if you perforate, if you are either lose the patient, if you want to save the patient, it costs you almost to the tune of 2 lakhs. Either yes. One stage procedure or 2-stage procedure. So you have to be very careful.
Especially if it is a poorly prepared colon, it is going to be a big mess. So I thank Dr. T.S.C. for this wonderful talk. It was really good. And Usha wants to say something?
Yeah, I just wanted to re-emphasize to all the postgraduates that apart from preparing the patient, you have to prepare yourself before you do the procedure. And what Dr. Chandrasekhar has highlighted, such key points in your learning process. So please read and see videos and learn from withdrawal and then learn to insert the colonoscope. And suction is key in colonoscopy. So, and eventually everybody will learn. So there is no need on a particular day to say that I reached the terminal ileum. There is no need. It is a staged procedure. And if you learn in a structured way, you can learn better. Thank you, Dr. Chandrasekhar, for an excellent talk.
Ma'am, I think with the permission of panelists, I would like to make a quick announcement for the postgraduate. So there are mainly 2 announcements. First, please note these things that at the end of each session, we will have a quiz which comprising of 5 questions which are relevant to that day's topic. And all the postgraduates are supposed to answer this question, 5 questions. And 3 winners will be declared based on the accumulated scores of 12 sessions at the end of the entire program, that is in December 2022. Moreover, all the postgraduates who have attended 80% of the sessions, that means 10 sessions out of 12 sessions, and who have attended more than 50 questions out of 60 questions, will also receive a course completion certificate. So this is very important announcement for the postgraduates. So please attend the entire session and try to attend the questions as well, because 3 winners will get exciting academic prizes. Thank you. Hand over to chairpersons. Thank you, sir.
Thank you. And I think we will move to the next talk, that is by Professor Amit Datta. He is from CMC Vellore, and he is going to discuss on some very pertinent topic, and it is a topic of current interest. And I'm sure that almost everybody doing endoscopy and colonoscopy are doing these techniques of image enhancing techniques, whether it is chromoendoscopy or electronic chromoendoscopy or different types of image enhancing techniques. And now we know that we have got newer technologies like endocytoscopy. So many other new things are there. But to know about NBI, which is a very relevant topic, we have Professor Amit Kumar Datta from Gastroenterology Department of CMC Vellore going to discuss on that. And he is a very well-known figure in this field, and he doesn't require any introduction on that. And he is in the field of Asian endoscopy, and he is actually a very important member of a teaching faculty of narrowband imaging. And I'm sure he's going to tell us from the very basics how to learn NBI for the postgraduates. So can I request Professor Amit Datta to give us this lecture? Thank you so much.
Yeah. So thank you, sir, for the kind introduction. Is my slide visible, sir? Can the slide be visible?
Beautiful.
Yeah, thank you, sir. So first of all, I'd like to thank Professor Usha Datta and the organizing team for giving this opportunity to me to make this presentation. So I'll be speaking on the clinical applications of narrowband imaging. So before I move on to the clinical applications, a few words about narrowband imaging in general, because it's a postgraduate program, and some people may not have an idea about this technology. So essentially, narrowband imaging is a form of image enhanced endoscopy. So when we say image enhancement, what we mean is that we want to enhance the image which we are seeing so that we can see more details of the mucosal surface, actually, so that you can see things in much more detail and pick up an early lesion. Now, narrowband imaging, what happens in narrowband imaging is that instead of a white light, there is a filter which filters out two narrow wavelengths of light, one in the blue region, one in the green region. And so the image is obtained by these two wavelengths of light, and that's why it's called narrowband imaging. And along with the narrow wavelength of light, this technology also uses a high definition television, which improves resolution, and the images are magnified. So as a combination of this all three property, the narrow wavelength of light, the high definition television, and magnification, you see an image which is really enhanced. So as you can see in this picture, you can see relatively flat appearing mucosa of duodenum on white light. But when you use NBI, you can start seeing the villi, you can start seeing the vessels inside the villi. So that's what narrowband imaging is. It's a form of image enhanced endoscopy. So this slide shows a snapshot of how different part of GI tract appear in NBI. This is the esophagus, the Z line, the stomach, the body of the stomach, antrum. This is the villi in the duodenum and the colon. So straight away we can appreciate how different these parts of GI tract appear on a narrowband imaging compared to what we are used to seeing on a white light endoscopy. So therefore, for us to use this technology in our practice, we need to know how different part of it appears in NBI, and then we'll be able to appreciate any abnormality in that area. So therefore, we should be familiar with how patterns are in different part of the GI tract. So the two very important things which we are assessing when we are doing narrowband imaging is called the vascular pattern or the microvasculature and the surface pattern. These are two essential components which I'll be talking repeatedly in my presentations. When you're describing or when you're identifying a lesion on NBI, you're looking at the vascular pattern, you're looking at the surface pattern, and we have to know what the vascular pattern is in different part of the GI tract, what the surface pattern is. For example, in stomach, you have pits. In colon, you have pit. Duodenum, you have villi. In esophagus, there is a flat surface because of the stratified squamous epithelium. So we need to be aware of the patterns in different part of GI tract to identify, to assess an area and also to identify a lesion. So this is a quick video just to show the steps of doing an NBI assessment. So we always begin with doing a good cleaning of the mucosa. So always remember, whether you're doing a white light endoscopy or any endoscopy, clean the mucous surface of all the debris properly, and then start with a white light examination. Do not jump to NBI straight. You always start with a white light examination, do a good white light examination of that area, and then you have to then proceed to a NBI. So washing, doing a white light examination, then you switch to narrowband imaging mode. And then depending on the type of the instrument you have, if you have a near focus, you go closer. And then once you're closer, you can freeze the image. So this is very important to learn to freeze the image, because once the image is frozen, then you can appreciate the pattern better compared to a moving image. The other thing, as you can see in this image, there's a cap at the end of the scope. And especially in the upper GI tract, when I do NBI, I use a cap because this cap helps me to get a very stable image. So again, washing the mucus and debris of the surface, starting with a white light examination, then going to narrowband imaging. Once you're near focus mode, learn how to freeze the image so that you can appreciate the pattern properly. Then how do we report the findings of NBI? So when we are doing an narrowband imaging, then you have to also describe your findings actually. So this is what I do in my practice. You describe the appearance on a white light endoscopy, what like you do for a regular endoscopy per se. And then the abnormalities which you have picked up, those areas need to be described using the narrowband imaging findings. So you describe where the lesion is located, what is the extent of the lesion. Then, as I said, the two important things, the microvascular pattern and the microsurface pattern. So what is the microvascular pattern in that abnormal area? What is the microsurface pattern in that abnormal area? And then, as I'll be discussing in my presentation, there are different classifications for different lesions. And then you try to fit in your pattern which you observed into a classification, if possible, which should be in most cases. And then finally, you have to give your interpretation. What do you think the lesion is? Is it a Barrett's with dysplasia? Is it an adenomatous polyp in the colon? Is it an early gastric cancer? So these are the main things: location and extent, microvascular pattern, microsurface pattern, what is the classification, and then your own interpretation of the finding. So this was about a little bit about the NBI technology and how we go about doing NBI examination. Then we go on to the clinical application, which is the main emphasis of today's presentation. So for clinical application, we begin with esophagus. So as I said that when you do NBI, you need to know what the pattern is in different part of GI tract. In esophagus, there is stratified squamous epithelium. So therefore, there is no pit. The surface appears flat. Okay. So therefore, you don't have to worry too much about the surface pattern in the body of esophagus. Now moving on to the vascular pattern, there are two types of blood vessels you see. You see these deeper vessels, you can see this deep, thicker, greenish vessels with branches. These are the deeper vessels. They are not too much relevant for a superficial lesion. What is most important in esophagus are these superficial vessels, which are called the IPCL or the intrapapillary capillary loop. So this is the key thing to assess for in the esophagus when you want to detect a superficial cancer, the IPCL or the intrapapillary capillary loop. Okay. So let's begin with a case scenario. So let's say you have a 65-year-old patient who has undergone therapy for pharyngeal cancer, and our patient is referred for upper GI endoscopy to screen for esophageal cancer. So we know that when you have a head and neck cancer, there is a higher risk of having esophageal cancer, and sometimes these patients are referred for surveillance. So if you're doing a surveillance to detect superficial cancer, can we do something to pick up lesion, more number of lesion than you can with a normal white light endoscopy? So there was this interesting study from Brazil which had 129 patients with head and neck cancer, and these patients underwent surveillance endoscopy. And in this group of 129 patients, they found 9 superficial cancers. Now, interestingly, only 4 were detected on white light endoscopy, whereas all 9 of them were detected on narrowband imaging or iodine. So therefore, I think if our aim is to pick up a superficial lesion, we should use an image enhancement, whatever technology we have, to pick up the lesions at an early stage. So how do you now identify a superficial esophageal cancer using a narrowband imaging? So the classification, as I told you, there are classifications for different lesions. The classification for esophageal cancer is called the IPCL classification. IPCL stands for intrapapillary capillary loop. So there are 2 things to look for when you are trying to do the IPCL thing. One is you look for an area formation. Usually the area which has the cancerous change is brownish compared to the surrounding mucosa. And then in this area, which is brownish, you look at the IPCL pattern. So this is the IPCL classification. Again, we can't go into too much of details because we have to cover a lot of areas, but just to tell you that there are classifications in different areas. So for esophagus and IPCL classification, the IPCL is divided into 5 types, the type 1, 2, 3, 4, and 5. And 5 is subdivided into 5.1, 5.2, 5.3, and 5.1. Type 1 usually denotes the normal mucosa, normal appearance. In type 2 and 3, there may be some amount of inflammation. But once you come to type 4 and 5, that's where you start seeing a high-grade neoplasia or a cancer. So as you go down from 4 to 5.1 to 5.2 to 3, you start seeing high-grade neoplasia, cancer, and this cancer gets more and more deeper as you go down the route. So the main difference between the 4, 5, and the rest is that one is the vessels are very thick. You can see they are much thicker compared to what you see in the remaining. Second thing is, instead of being a simple loop like you see here, they start being like a petal of flower or like multiple petals of flower or branching. So the pattern gets irregular. The vessels become thicker in type 4 and 5. Now with the endoscopes generally which we have, it may be difficult to sometimes distinguish 5, 1, 2, and 3. But if you can pick up a 4 and 5, to me, that is the job done, because that means you have identified a high-grade neoplasia or a cancer, and then patient can subsequently be sort of subjected to appropriate therapy. So identifying a 4 or 5 pattern is key. And as you do more and more procedure with better equipment, then you can sort of subdivide them into 5.1, 5.2, or 5.3. This is one of our patients. This is the appearance of esophagus on a white light. You don't see there's too much of change on a white light. But when you switch to NBI, you see there is a brownish color. There's an area of formation. So this area looks different from the surrounding area. Now in this area with brownish color, when we do a near focus, you can straight away see there is a type 5 pattern consistent with superficial esophageal cancer. Again, I'll run a short video. So this one, as you can see, we did a white light, then we went to the NBI examination. Then as you go closer to lesion, you can start appreciating this type 5 IPCL pattern in this patient, okay? Now here again, I'll just pause the image video. You just see that there is this area which is called brownish color compared to the surrounding area. And in this brownish area, you have a type 5 IPCL pattern. This again is an example of a superficial esophageal cancer. Now in this patient, when we sprayed Lugol's iodine, you can straight away appreciate there is a large area which has not taken up iodine. This is the area with the superficial cancer. So that was about superficial esophageal cancer. Next, we talk about Barrett's esophagus. So here again, I'll begin with the case scenario. A 60-year-old male patient with a previous diagnosis of Barrett's is scheduled for surveillance. Now, usually for surveillance, what do? We have the Seattle protocol where you take a 4-quadrant biopsy every 2 centimeters. But the problem with this 4-quadrant biopsy is that it only samples a very small area. And then there may be areas in between which have dysplasia, which are not being sampled. So is there a technology by which we can actually look at the mucosa in detail and in real time say that this area looks dysplastic, I should biopsy from here, this area does not look dysplastic. So if you could identify dysplasia in real time, then you can take targeted biopsy and then you can improve the yield of dysplasia. And this is possible with image-enhanced endoscopy like narrowband imaging. So how do we identify a Barrett's esophagus and dysplasia on NBI? In terms of pattern, Barrett's, the thing is there is no one type of pattern for Barrett's. Barrett's, the surface pattern can be round, it can be a ridge pattern, it can be this villus like this, this cerebriform pattern like the gyre of the brain. It can be a villus pattern. So you can have any type of pattern for a Barrett's esophagus. So therefore, for the primary diagnosis, you still depend on the biopsy to confirm it. To me, the main strength of NBI lies in surveillance in detecting dysplasia. So then how do you diagnose a dysplasia using a NBI? So for this, again we have a classification which is called the Bing classification, which stands for Barrett's International NBI Group Classification. This actually is a very simple classification. They look at the mucosal or surface pattern and the vascular pattern. Now, in the surface pattern, which is either circular or ridge or tubular, whatever the pattern is, if there is irregularity, you suspect dysplasia. Similarly, for vascular pattern, whatever the pattern is, if there is irregularity, you suspect dysplasia. And you don't have to have both of them. Even if surface is irregular or vascular is irregular, it's sufficient to suspect dysplasia, and this has about an 85% accuracy. And then that area you should go and take a targeted biopsy. So again, I'll just run a small video sort of just to show how do we assess esophagus Barrett's using NBI. So again, we begin with a white light examination to inspect the area properly, look for any nodularity, ulcer, depression, etc. And then we switch to the narrowband imaging mode. So begin with a white light examination, then switch to narrowband imaging mode. And once you have localized the lesion, then you go to the near focus mode, then inspect the entire area. So the key thing here is to inspect the entire area with Barrett's, look at the surface pattern, look at the vascular pattern, and see if any area has any irregularity. So like, for example, in this case, everywhere the pattern seems quite regular, so there's no dysplasia in this particular case. But the key thing is starting with a white light, going to NBI mode, then examining the entire area thoroughly with your NBI. So this may need some time. So I think it's good to give the patient some sedation. And again, I think I must say the use of cap is actually critical when you're assessing dysplasia, looking, especially in the G junction, that area can be narrowed, and therefore cap is so, I think we should always use a cap when you're doing NBI, especially in the upper GI tract. So what does the literature say about the yield of NBI in Barrett's? Now, NBI has been shown to pick up more patients with dysplasia. It detects higher grades of dysplasia, and also it's been shown to require fewer biopsy samples. In fact, a meta-analysis has shown that the sensitivity to identify high-grade dysplasia is 91% and specificity is 95%. So it's very good in picking up dysplasia in Barrett's. This is one of our patients with Barrett. This is how it appeared on a white light examination. When we did NBI, we found that everywhere the pattern is regular. So in this situation, if you use the Bing classification, the surface pattern is regular, the vascular pattern is regular, so there is no dysplasia. But remember that NBI as of now is still not a substitute for 4-quadrant biopsy, and still there's a recommendation that you should do a 4-quadrant biopsy. But in this case, with a regular pattern, you can take biopsy from anywhere you feel like, because everywhere the pattern is similar. It's another of our patient here. This patient had a long segment Barrett's esophagus. This is how it appears on a white light examination. On NBI, what we can appreciate that there is one area here which has got this irregular vascular pattern. So therefore, in this patient, when we use NBI, then we know that I have to definitely take a biopsy from here. Whereas if you only had a white light endoscopy, you may have biopsy from this area, and you may have missed this area. So that's where the strength of NBI lies, that it can tell you which area looks dysplastic, and you can go and take a targeted biopsy. So that was about esophagus. We discussed about the IPCL for superficial esophageal cancer. We discussed about the Bing classification for Barrett's dysplasia. Now we move on to the stomach. So again, for stomach, before we can pick up an abnormality, we need to know what is the normal pattern in stomach. Now in stomach, the pattern in body and antrum is slightly is different from the pattern in the antrum. So in body, the pits are actually round, and surrounding these pits, you have this dark honeycomb-shaped structure. These are the vessels which are called the subepithelial capillary network. So the microvessels or the SCCN are in honeycomb pattern surrounding the round pits. And then you have this brown long structures with branches, these are called collecting venules. So you have round pits, you have honeycomb shaped microvasculature, and you have deeper this collecting venules. In the antrum, the pits are not round, but they are this wide structures are zigzag, elongated, what is called as a reticulate pattern. The blood vessels, which are honeycomb pattern in the body and antrum, here they start getting coil shaped. You can see the brown structures are all looking like coils. And the collecting venules, which you see in the body of stomach, you don't see them in the antrum. So antrum has reticulate pits and it has coil shaped vessels. So again, let's talk about a case scenario. So let's say you have a 55-year-old patient who's come to you with dyspeptic symptoms. The patient does not have any alarm symptoms. His brother had gastric cancer at the age of 43 years. When this patient had a previous endoscopy, he was found to have extensive intestinal metaplasia. And he's been treated for H. pylori infection in past. So here we have a patient actually who's got risk factors for gastric cancer. He's got extensive intestinal metaplasia. There is a family history of gastric cancer. He had H. pylori infection in the past. So now in this sort of patient, we know that he's got a high risk of developing cancer. So can we pick up lesion early? If we wait for this patient to develop symptoms, then it's usually late. So by the time the gastric cancer patients have symptoms, the tumor is at an advanced stage and most of them cannot undergo a curative resection. So in such a patient, if we come across, can we detect cancer at an early stage? And now there are guidelines from the West and the European countries that when you have such a patient, they should be kept on a 3-yearly surveillance program. And the surveillance should be preferably done with a high definition or an image enhanced endoscopy. So we'll discuss how we can detect early gastric cancer using narrowband imaging. So if we remember the pathway of gastric cancer, it begins with H. pylori associated gastritis, followed by atrophy. Then you have metaplasia, followed by dysplasia and cancer. So what are the changes which come across in somebody who has H. pylori infection? So I have just described what a normal appearance of stomach is on NBI. You have the round pits and you have this collecting venules. Now, one other thing which happens in H. pylori is that this collecting venule, this dark brown structures with branches which you see, they disappear. So this is one of the very sort of about 80 to 85% of cases with H. pylori will have this collecting venules missing. That's one feature which you see in H. pylori. So the white structure is still round, the honeycomb pattern is still maintained, but this dark brown longest branching structures, they are not seen. The collecting venules are not seen. The second change which can come about is that instead of the pits being round, they can get elongated like the way you see it in the antrum. So these are the two features which you see in patients who have H. pylori infection. Now, what happens in atrophy? When there is atrophy, then the pits are lost. And so therefore, in that area, you won't see a pit pattern. So for example, in this picture, you can see in some areas, you don't see any pit. Some areas, the pit pattern is intact. Some areas, you don't see any pit. These are the areas of atrophy where these are the normal areas. Now, what happens in intestinal metaplasia? Now, there are two main changes which come across. One of them is that the pit, I told you that in the body of stomach, the pit is round. In metaplasia, instead of round, the pits becomes elongated or tubulovillous. So you can see in this picture, these white structures are elongated. They are more tubular. They are not round anymore. So that's first thing. There is a change in the configuration or the morphology of the pit. Now, along with the change in configuration, you start seeing one line which is called as a light blue crest. This is a very important finding, very specific finding for intestinal metaplasia described by Dr. Uedo from Japan. So if you look at this picture here, you can see a fine line here, another line in this area, another line in this area. This line is what is called as a light blue crest. So when you see this line along this tubular elongated structure, then you are fairly sure that this patient has intestinal metaplasia. Next, we move on to gastric cancer. So again, there is a classification for gastric cancer, like the same way we have for esophageal cancer, we have one for gastric cancer. And the classification, which is quite popular outside of Japan, is the VS classification, which is proposed by Dr. Yao from Japan. So V stands for vessel, S stands for surface. So to apply the VS classification, there are two things to do. First step is to look for a demarcation line. So what is the demarcation line? A demarcation line is basically an imaginary line which denotes that there is an abrupt change in pattern. So if you look at the pattern in this area, and this is an abrupt change of pattern. So when you have an abrupt change of pattern, then that area, that line is called as a demarcation line. So as you can see a change of pattern here. Similarly, there's an abrupt change of pattern from here to this area. So first step is to identify a demarcation line. Now, once you have identified a demarcation line, then within the demarcated area, you look for any irregularity of the vessel, which is V, or irregularity of surface, which is S. So if there is a demarcation line present, and in addition to that, within the demarcated, if you have irregular vessel or surface or both, either or both, if any of them irregular or absent, then you are more than 90% sure that this patient has a gastric cancer. So again, I'll run a video from one of our patients. So here again, we begin with a white light. We clean the surface of mucus and debris. You can see one erythematous lesion on the white light examination. Okay. And then once we have done a white light, we switch to NBI, and straight away you can appreciate this irregular surface pattern here. The irregular looking surface pattern, the blood vessels in this area look quite irregular. Now you have to examine the entire lesion to get an idea about the extent of lesion and what the pattern in different areas is. So here again, you can appreciate this very irregular appearance, all different shapes of surface. Okay. This is the demarcation line, easily seen normal area and abnormal area. And in that demarcated area, we're looking at the surface, which is very irregular. So this again fits into your description of a early gastric cancer by the VS classification. This is a picture again. If this is a white light image and an NBI image, on white light image, you can see one area which looks a bit pale. Now, if you're not very careful, you may pass it off as normal. But if you look carefully, there is an area which has got a pallor. And this area, when we apply narrowband imaging, straight away you can appreciate there is such a difference in this area compared to the surrounding area. So let's apply the VS classification for this. So the first criteria for gastric cancer is you should have a demarcation line. So here again, is there a demarcation line? There is, because if you look at this area, the pattern in this area, there is an abrupt change in pattern from here to here. So there is a demarcation line. Once you found a demarcation line, then you look at the demarcated area for any irregularity of vessel or surface or both. In this case, you can easily see there is an irregular vascular pattern in this area. So this is an example of early gastric cancer based on the VS classification. This again tells you the strength of this technology, because if you didn't have an NBI in this case, probably you will call it as a pale mucosa. You can pass it off as normal also as well. So I think the patients who are high-risk patients where the risk is high, probably if you want to really pick up cancer at a treatable and early stage, it's good to do an image-enhanced endoscopy. But again, you can't do this for every patient with dyspepsia. So because you don't have so much of resources, it's time-consuming, it's expensive. So you have to identify who is the patient who's going to benefit. So the case scenario I showed you here is a patient who would really benefit. There's no family history of gastric cancer, extensive metaplasia. This sort of patient is one where we should subject to NBI, but not every patient at this stage. Now, what does the literature say about the yield of NBI compared to white light? And again, a systematic review and meta-analysis has clearly shown that the sensitivity and specificity of NBI is much better than white light in detecting early gastric cancer. Now, as we're running out of time, I'll just quickly go through colon. So we've covered esophagus, where we had IPCL pattern for superficial cancer. We had the Bing classification for dysplasia and esophagus. Then we covered stomach, where we looked at what changes come across with H. pylori, with metaplasia, and then how do we apply the VS classification for gastric cancer. So in colon, again, if you look at the normal pattern in colonic mucosa, it is somewhat like you see in the body of stomach. We have these round pits and the honeycomb-shaped blood vessels, but you don't see the collecting venules which you see in the body of stomach, actually. Now in colon, the main application is actually in characterizing a polypoid lesion in the colon. So let's say if you have a 55-year-old patient who undergoes colonoscopy, and during colonoscopy, you find a 3 centimeter sessile lesion. Now, what is the likely histology? Can you identify the histology? Can you predict that what is the likely? Is it an adenoma? Is it a carcinoma? Is it a hyperplastic lesion? And then how should we manage this patient? Does the patient need an EMR? Or the patient requires an EST? Or should he be sent for surgery? If it's invasive cancer, it has to go for surgery. Superficial lesion can be treated with EMR or EST. Now, NBI helps us to make these sorts of predictions. It can help you to predict what is the underlying histology, and it can also help you make some treatment decisions about what should be the appropriate management strategy. So for identifying a polyp, characterizing the polyp, what is the type of polyp, we again have classification. And the classification I find very helpful in colon is the kudos pit pattern. Now, this pit pattern actually came in before NBI was into practice. This is mainly based on the microsurface features, not on the vascular pattern. So kudos pit pattern divides the pits into 5 types. You have type 1 and 2, which are round or stellate. They denote hyperplastic or non-neoplastic lesion. You have type 3 and 4, which elongates white, elongated or branching. So tubular or branch tubular structures. And then you have the type 5, which is non-structural pits. So basically, when you have round or stellar sort of appearance, it's hyperplastic or non-neoplastic. When these rounds, the white structures get elongated or they get branched, then it is adenomatous. And then when these are sort of non-structural, missing, amorphous, then you suspect invasive carcinoma. So for the NBI classification for colonic, we have this classification called the NICE classification, or the NBI International Colorectal Endoscopy classification. Now, this classification looks at three aspects of polyps: what is the color, what is the vascular pattern, and what is the surface pattern. And based on this, it divides them into type 1, which is hypoplastic, type 2, which is adenomatous, and type 3, which is a submucosal invasive cancer. The surface pattern which they have taken is similar to what it is for Kudos pit pattern. So Kudos type 1 and 2 fits into type 1. Kudos type 3 and 4 fits into type 2. And Kudos type 5 fits into type 3. In terms of color, the type 1 or the hypoplastic are lighter or same color as background, whereas an adenoma or carcinoma is browner compared to the background mucosa. The vessels in type 1, don't see much vessel. They'll be faint vessels, not very easy to see. Whereas in type 2, the brown structure of the vessels are very easy to see. You can see the brown structures of the vessels quite easily here compared to in type 1. And in type 3, there are disrupted, or some areas you'll see vessels, some areas they're missing, some areas again they'll be seen. Okay, this is how you classify a lesion based on NICE classification. One of the limitation of NICE classification is that the type 2 can include a low-grade dysplasia, a high-grade dysplasia, even a superficial cancer. So therefore, to overcome this limitation, this JNET classification was suggested, where the 2 was split into type 2A, which is low-grade dysplasia, and 2B, which is high-grade dysplasia or even a superficial cancer. Again, because of lack of time, I can't go through the details, but these are easily available and we can go through. So again, when you look at the differentiating power of NBI between neoplastic and non-neoplastic, the performance is very good. It's got 91% sensitivity and more than 80% specificity in differentiating neoplastic from non-neoplastic polyps. So again, I'll just run a quick video of a rectal polyp seen on NBI. So as I said, you always begin with a white light assessment, see the lesion, describe the findings, and then we can move to the narrowband imaging mode. So again, a polyp may have different pattern in different parts. So therefore, it's very important to examine all the areas of the polyp actually, okay? So for example, like in this polyp, let's say if you look at this area here, I think we'll just get the image in that area. So if you look at this area, you can see so as I told you, if you think of the Kudos pit pattern, the white structures here are elongated. Now, elongated white structure is Kudos pattern 3. And the blood vessels are dark brown, they are easily visible. So easily visible dark brown vessels, the white structures are elongated. So this fits into the NICE 2 classification of JNET 2A, which is an adenomatous lesion. Now let's look at another area in the same polyp. So this is one area which we have seen. Now if you look at a different area in the same polyp, let's look at this area. And we'll just freeze the image here. So here if you see, the white structures are still looking like elongated white type 3 or 4, but the blood vessels are quite irregular. So this is an area which has a high-grade dysplasia. So you can see with NBI, you can real-time see some part of polyp has got low-grade dysplasia, some part of polyp has high-grade dysplasia. And this is another example of a lesion. Again, this is how it appears on a white light. But when you do NBI examination, what you find is that you can't appreciate those white structures at all. So this is amorphous surface pattern. And these blood vessels, some areas you see them, some areas you don't see them. Again, some areas you see them. This is typical of an invasive cancer, how invasive cancer appears on NBI. The one area where NBI was a bit disappointing was in detection. People thought NBI is image enhancement. You'll pick up more colon polyps when you do a screening endoscopy. But somehow, when there was a screening, it didn't pick up more lesions than a white light endoscopy. But as time has gone by, as better scopes have come in, now it's clearer that if you use the newer equipment and if the colonoscopy preparation is very good, then NBI does help you in picking up more polyps compared to white light examination. So just last few slides, because I can't cover other applications, but just to tell you that there are a few other applications also which are emerging. One of them is that when you have somebody with ulcerative colitis, in these patients, when you're doing a surveillance, one recommendation is a dye spray chromoendoscopy, but you can also do an NBI and you can pick up a dysplastic lesion. Other is when you have a malabsorption with NBI, the villi can be easily seen, as you can see in this picture. So when there is a villus atrophy, they are very easy to detect on NBI. When you're doing an EMR and EST, then you want to make sure that the margin is free of any lesion. So with NBI, you can actually assess if the margin is free of lesion. So in conclusion, what I have presented is that image-enhanced endoscopy, it enables the assessment of mucosal surface in greater detail. It is better than white light in detecting lesions at an early stage. It already has an established role in detecting dysplasia and Barrett's early gastric cancer and characterizing polyps. One of the limitation is that it takes some time to understand and appreciate the patterns, and there's a bit of a learning curve to it. But there's a lot of progress happening in the field of artificial intelligence, and soon this will be there to help us and further use this technology for the benefit of our patients. Thank you for your attention.
Thank you, Amit, for this wonderful talk. Beautiful pictures, beautiful videos, and it was really a very learning experience. And thanks a lot. And to start the ball rolling, I just want to ask you: do you require any preparation for upper GI, like mucolytic agents, etc., to make the visibility by NBA better? And second aspect of that question is that when you use a cap, you use caps that are UV caps, they are transparent, there are black caps, and also can you use additional water to enhance the image bigger, make it bigger? So three aspects.
Yeah, thank you. So they're very, very important questions. So about using the additional thing to clear, so in my practice, I normally don't use, because the 190 system which we have, water jet is quite good to clear the area of things. So we sort of, but it can be done. So what I'm saying, it's no harm doing that. But in my practice, sort of, I use the water jet facility more often than using that one actually. In terms of cap, which you have asked, so I use the soft black cap actually, the one which we have. And I think with the cap, I think it says it, cap is actually essential to use it in the upper GI tract, especially colon. I don't use cap that much, although, but in upper GI it's critical, especially for the Barrett's, that area and G junction. If you don't use a cap, you will not get the image in focus that easily. So therefore, cap is very helpful. The one thing we take care is that when you're using a cap, we don't rub against the mucosa very hard, otherwise you'll get a ooze, and that will hamper your field of vision. Underwater, again, I think in duodenum, I use it frequently when I use in duodenum. In other parts also, sometimes when you don't get a very stable image or there's a lot of things, underwater does help us in visualizing. But that I use more in duodenum. Rest of the areas, sometimes I use underwater.
I think in duodenum it is very important, especially even before MBA came, people used to do instill water into duodenum to look for picking up celiac disease and looking at the villi and all this. Actually, it really magnifies the images better. So I think that is a good one. And in colon, why in colon caps are not used?
Can be used, I think colon, what I'm saying, if you look at the applications wise, the main application right now is characterizing the polyps of different types actually. And there I think you get a fairly good image even if you're at some distance, because you're looking at this kudos type 3 and 4. In fact, the kudos pattern is actually sufficient to tell you the type. The vascular pattern is additional information you are getting. So there, even if you don't have a fixed distance, you are able to appreciate. But having said that, it can be used. It's just that in colon, mainly it's characterizing and differentiating between different types of polyps, which you're able to do. But I guess maybe for a beginner, it's good to use. And if it's like a flat lesion, very sessile, there it may be helpful to use a cap in colon. But otherwise, for elevated sessile lesion, we can get away without it.
And many times in colon, we have elevated lesions, or even if they are sessile, they are actually a bit elevated, or lateral spreading lesions. Yeah. And it is not that difficult. And moreover, with a cap to go up to cecum also, sometimes it's difficult. So it's better.
True, sir. Very true.
So in rectum, if you can, I think you can do it. And one more interesting thing which I noted, that how do you document your findings when you do a NBI? Do you have any assistant? I have seen in places there is an assistant, he is writing it, and you take the pictures. And another is, you take pictures and you finish the procedure and sit down and start writing. How do you do that?
So what I do, so normally for me, like NBI usually is we have a priority in my mind most often, the targeted examination. We're going to look at something in the stomach or something in the esophagus. Like known case of Barrett's has come for a surveillance, or somebody high risk of gastric cancer, you're looking for any early gastric cancer. Since I already know which part I'm going to examine beforehand in most patients, I just keep saving. I tell my assistant to keep saving images as I go. Because once I save the images, I'll be able to recall what I have seen from the areas, because it's the area which has got abnormality which I'm more interested in. And so I will see which area that is. I'll save pictures from that area. And then after that, I will describe that finding. So it's not very difficult if you're doing a focused or targeted examination of one or two areas. But generally, if you're looking at the entire tract, then you may have to probably, real-time document. Otherwise, you will forget what you saw. But if it's a focused small area examination, just saving pictures and doing later is also okay. What I do in my practice.
And one more thing, when you do an upper GI endoscopy, even if it is a high-risk patient, yes, how do you find out in white light what are the areas which you need to look at? Because in white light, sometimes areas may be very subtle, and or when you put a narrowband into a wider area, is there any area which is there anything which can tell you that you should see these areas?
That's again very important point, sir. So actually, last 4-5 years now, I have been starting using this NBI for my patients who are having extensive metaplasia. Earlier, we didn't, because that's one group. If you're doing an endoscopy and you're picking up metaplasia and if already they are known to have it, I'm putting them on a 3-yearly. It's not for everybody in the department, but patients which I see, I'm doing that procedure. So what I do is when I do this patient surveillance for a gastric cancer, I will first do a white light assessment. Look for any subtle change in color. There may be like one case showed an erythema, one case had a pallor actually. So there's a subtle change of color. In those areas, you can do a targeted assessment with NBI where there's a change in color or there's erythema or there is some depressed area, some nodularity. If you see those subtle lesions, you do a focused examination. And once I have done a white light and targeted examination of abnormality on a white light with NBI, then I do an NBI scanning of the entire stomach, which is possible. If you do more procedures, you should be able, even though people talk about illumination, but if you go closer to the surface, the illumination is quite good with the 190 system. You can look at the stomach in detail. To your question about the which side, so one area which you should look more carefully is that lesser curve area. I think that's the area, lesser curve and incisura, those areas where you tend to see a lesion a bit more often than the other areas actually. And that area also sometimes in a normal, you may not even, your scope may not be head on looking at that particular area, and sometimes you may miss. So retroflexion may be a good position also to examine some areas in endoscopy. So a white light, picking up a suspicious area, doing a targeted examination, and then one general scanning with NBI, going closer. It takes about 8 to 9 minutes to do this, is what I would in my practice. Just for stomach. Yes, sir.
Pardon?
Just for stomach it takes, yes, sir.
Yeah. I think it is very important to have very good, proper white light examination, and you should be, your eyes should be very carefully looking at that. The mucosa should be clean, and you should actually use liberally the washing, the water jet, and 190 is very good for that. I also have noticed that when you use a narrowband imaging, this is actually it's taught to me in the past when I started doing NBI many years back. If you see a black area or a brown area on a narrowband imaging, then you should go and see that area. Do you think that is right?
So in the stomach, the thing is, what I mean, this maybe it's like you're screening. When you screen, you'll pick up a lot of alarms will come. Some areas will be okay, some areas will be having a lesion. So when there is an inflammation in the stomach, when there's a congestion, inflammation will become dark because of the more blood flow. So even in a gastritis with inflammation, you will have dark appearing areas, especially in the antrum, you see this antral erythema and all, you'll be having dark appearance. But what that tells you that area you should go with NBI and examine. And when you do NBI, you find the pattern is exactly the same in a normal, but the vessels are very dark. So that is just inflammation. It is not conforming to any cancer or any metaplasia. So therefore, that just red flags you to examine it properly. With NBI, it's quite easy to differentiate just a congested inflamed area from a malignant area or a metaplasia.
There is a question by Dr. Bilal Ahmad from Cochin, and he's asked question. There is a WASP classification of colonic polyps which incorporate NICE in it, and it is worth to consider to describe the polyp. So kindly comment on that.
No, that's a very good. In fact, I had a slide, but then because the time was such a big area to cover the GI tract, I had a slide and then I deleted towards today morning, because I was not somehow this thing. So actually, that's a very good question. See, the thing with NICE classification of JNET is that the type 1 lesion they are calling, that is hyperplastic. But this lesion, which is sessile serrated adenoma, also appears like type 1. Then we know that SSA has a potential for malignancy, whereas hyperplastic per se doesn't have too much of malignancy. So we have to differentiate the sessile serrated adenoma from a true hyperplastic lesion. So now people are coming up with some classification, and one of them is the WASP classification. You look at the clouded surface, irregular border, the margin. So there are some 3 features you look at in the WASP classification. And if you have those classifications out of the 4, there are 4 features have been described. If you have 2 features to suspect, but then that classification has come from just one group in Europe, it still has to be validated in a larger group. So therefore, as of now, it can just be a thing. And that's the reason why when you come across a type 1 lesion in, say, except for the rectum where the SSAs are not very common, in the rest of the colon, if you see even a type 1 lesion, we still biopsy, we still remove them because they can still be an SSA. I think the main benefit of NBI probably is in that type 2 and 3 where you should leave alone for a cancer or do an EMR on AST. But type 1, because of the SSA, we still remove whether it's except for the rectum, sometimes we leave, otherwise we tend to remove all the type 1 lesions as well.
There are 3 more questions. I will quickly go through that. And one is that artificial intelligence, is it available now for NBI-based diagnosis? And is there a real difference between using NBI versus chromoendoscopy?
Yeah. So for artificial intelligence right now, I think what is ready for prime time is the colon polyp detection with a white light, which I think is now coming up. NBI, I would say, is still a work in progress, I think, for the NBI thing. But for the colonic polyp per se, the AI is available. So maybe that AI can tell you that there is a polyp, and then you can go with NBI and you can at least look at that area and characterize the polyp. But for picking per se, I think it's a work in progress right now for this. So what was the second question, sir? The second...
Chromoendoscopy versus...
Yeah. So chromoendoscopy, the thing with chromoendoscopy is the dye, what I assume when you say chromo, probably they mean a dye spray chromoendoscopy. Because NBI is also a form of chromoendoscopy. NBI is called digital chromoendoscopy, and the other one is a dye spray. In the dye spray chromoendoscopy, you are looking mainly at the surface pattern. You don't assess the vascular pattern. Whereas with NBI, you assess both the surface pattern and the vascular pattern. So there is an added benefit, especially in early gastric cancer or other lesions. I think a vascular pattern assessment is quite important. So therefore, NBI probably has this added benefit of looking at the vascular pattern, which a dye spray does not help you with.
Yes, agreed. I think, because if you want to study a wider area with dye, it becomes more messy and it becomes difficult sometimes. So chromoendoscopy has definitely advantage because you look at two things, the vessels and the surface pattern.
And also, so once you have sprayed, you can switch back to the normal mode. Where NBI, you can with the press a button, you can go to normal mode, digital mode. And
once you spray the dye, then you cannot switch it back, But you can do in NBI you can do that. And artificial intelligence is available with endocytoscopy, but it is going to come in conventional NBI. But people incorporate NBI also in endocytoscopy, so we can, for vascular pattern, you can use artificial intelligence that. I'm sure it is going to come. And another question is by Ishwara Murthy about difference between gastropathy and gastritis in NBI.
Again, there's not much of literature on that because NBI is mainly focused on picking up neoplasia and pre-neoplastic lesions. This gastropathy and all, they will be just having some changes in the vasculature. There'll be more dense, sort of, more blood flow, darker areas, but there's no literature about how to differentiate a vasculopathy from this thing. So any comment you want to make, sir, on this? There's nothing from what I'm aware of, actually.
This is actually NBI. People should realize that it's for a diagnosis of neoplasm or a pre-neoplastic.
Yes.
And of course, we have pick up in industrial metaplasia for H. pylori and also for celiac disease in the duodenum. These are all different things, but it's basically intended for looking at the vascular pattern and the cellular, and the mucosal pattern. So that is very important. And one more thing is that a comparison between AFI and other endoscopy systems, image enhancing techniques. This could be the last question, and I can see that the organizer standing in the podium looking at me.
So AFI, to tell you the truth, AFI came in with a bit of a promise initially, but as time has gone, now we are not hearing too much about AFI because the NBI with the 190 system and the newer ones, I think it's giving a lot of information. So probably, if you look at the current literature, it actually has come down in terms of the AFI, and there's not too much of comparison because AFI tells you different thing from what an NBI maybe is a part of it, So therefore, I think of late, we don't talk too much about that, and I think you do NBI or any other form of enhancement is what is more important.
I think Tahir Majid question is answered for you. And there are so many new techniques coming up. Of course, this area is a very vast area and it's going to be increased and it's going to be enhanced as well. And to finish everything in 30 minutes is practically impossible. Colon itself is a big topic. And I appreciate and thank you for being very simple and clear-cut discussion on, especially on the upper GI. You have elaborated it very well and people could understand it very well. And colon, you gave us a brief idea that is enough for us, but maybe at some point of time, we can have one more discussion on the colon because it is a very important area. So back to the organizers, and I would appreciate and thank the organizers for giving me this opportunity to be a part of this important learning process. I learned a lot. Thanks, Usha, and all the organizers of e-Pathshala.
Thank you so much, Dr. Matthew Philip, for conducting this session so well. And thanks, Dr. Amit, for a very clear and lucid presentation on NBI. I agree this whole topic would itself have taken 1 hour, but I think it is just a way to stimulate our postgraduates to know the potential of NBI.